let us focus our energy on people who are most vulnerable to the disease. That's why we created that working group on prevention of mother-to-child transmission. The outcome of the research is that we had a number of interventions that work. We knew, we can't just ignore the fact that we have treatments and they're not available. We need to make it available.
Thank you so much for joining us again today for our third episode of Health Access Now. With World AIDS Day just around the corner, I'm going to ask Dr. Saba about his experiences during the AIDS and HIV epidemic. Today is going to be a great episode, so thank you so much for joining us. And also, Dr. Saba, thank you so much for sharing your insights with me today. I'm really enjoying bringing this content to the audience, and we're getting lots of great feedback, so I really appreciate your time. I'm really excited about the future episodes of Health Access Now already. That said, if any of the audience have any questions or any issues they'd like to hear Dr. Saba's insights on, please feel free to reach out to us on our platforms, on our YouTube page, on our LinkedIn channel, and we look forward to bringing or addressing those questions in future episodes of Health Access Now. So with that said, we're going to get started with our first question. With World AIDS Day just around the corner, I thought it would be interesting for our audience to hear a little bit more about your story. In our first episode, you mentioned that you started your career as a medical doctor in Lebanon. Can you tell me a little bit more about why you decided to move to France?
Yeah, I decided to move to France to do my specialty in infectious diseases because I was trained as a generalist. I finished my medical studies and I needed to do my infectious diseases. But there was more to it. Beyond my training, I needed to do something more impactful than what I was doing in Lebanon. Now, you could say we were in war. I was dealing with a lot of, I would say, a lot of war surgery and problems related to the war. But I had that feeling when I was in Lebanon that I was treating soldiers for them to go back to the battle, and it was a civil war. People were shooting at each other, knowing each other. I mean, people say, Rudy shot me. It's like, this guy. How can they shoot you? So it got very ugly, and for me, it was very important also to have an impact, and I felt I had very limited impact. I had an impact on the individuals, but I needed to have broader impact, and I was helpless in Lebanon. So I moved to France and trained as infectious diseases, and this is where I got to treat the first patients with AIDS, and they were all my age. They were young people, and I remember particularly one that was really my age. He was married, and he could have been my close friends, and we stayed together for 5-6 years together, helping to treat him. So that's why it was different, and I needed to have that impact. And with HIV/AIDS, I had also no impact because I had people were dying and we had no treatment for them. So I needed to find a treatment, and that's how I got into research and became a researcher, not only a physician who takes care of patients.
Mm-hmm. It's like in some ways you've almost answered my question there, but still, so you were working, I suppose, as a medical doctor in Lebanon. You felt like you were putting a band-aid on a much bigger problem, and you didn't have the tools to create the impact that you knew you had the capabilities of, or at least that you were really passionate about.
When I was working as a researcher and as a clinician, we were doing a number of research on opportunistic infection. We weren't at the stage of having antiretrovirals. We had some AZT, but it wasn't working very well on its own. And then I started, my patients' population has changed. I started seeing many more Africans coming. Not only, French or, men who had sex with men, or or IV drug users, I had, heterosexuals and many coming actually from Africa or from African origin. And that was the beginning of actually the rise of the epidemic in Africa. So I felt that it was an opportunity for me to go more international, have broader impact, even broader impact, and also look at the epidemic. So for me, that I dedicated my career to HIV/AIDS. I wanted to make a difference there. And that's how I joined WHO, and we actually went to Rwanda to work on preparing for clinical trials on HIV vaccine. Unfortunately, that never came, but that gave me that experience of Africa and Rwanda and these countries.
Okay, so at UNAIDS, you coordinated a multi-sector clinical trial working group for the prevention of mother-to-child transmission of AIDS. Can you tell me what that looked like? And what was the purpose of the group? Where did the research come from, for example?
Well, this was interesting. This was the beginning of a bright horizon for HIV/AIDS. Because even when I was in Rwanda, there was no treatment. We need to help in prevention. We knew prevention was not working. Its effect was limited. We started focusing on what we call targeted prevention, meaning let us focus our energy on people who are most vulnerable to the disease, people with high risk, sex workers, IV drug users, some of the women whose husband is high risk. So let's focus on high risk population rather than just keep sending general messages to the general population. And that became has limited efficacy, but it was more effective than the general population. So when we started seeing that antiretrovirals could lead, and we identified that giving AZT, which was it was a US trial, giving AZT to pregnant women, starting in week 14 of pregnancy, like at 3 months, if you want, the 4th month, until delivery, and then to the child, we could prevent successfully transmission from the mother to the child. So here we have something that can work, and this is where we started. The only issue is we couldn't apply it in many countries because we didn't see women at 14 on the 3rd month. We saw women on the 8th month, 9 months. So we can't just apply it. So we needed to do clinical research to see if shorter treatments could be as effective. And as a researcher with my boss and with Peter Piot, and we conceived the trial, but also we wanted to make sure that this time the international community are all looking at answering all research questions related to mother-to-child transmission. What we didn't want is to have trials after trials, so in 10 years we're still studying if it works. So we said, because there are multiple groups, let us try to make sure that we're answering all the questions. So let's define what the questions are and answer them. And that's why we created that working group on prevention of mother-to-child transmission that included all the people involved in this research to say, okay, are we answering all these? We shouldn't allow. So when we have a treatment that works, we know how to apply it. And that is the key element related to it.
So where were you meeting and how often did you meet?
Well, I mean, we create first, like, we didn't want it to be agency specific. In other words, we didn't want it to have one agency. What we wanted to do is we wanted people interested who are actually working on the trials to come in their personal capacity, because working interagency is very bureaucratic. I have never been a bureaucrat, so this is not the way it should work. So we got people interested and who wanted to make that difference, and we got together. We were meeting either in the US, we met in South Africa, we met in Geneva very often because I was based in Geneva, and as a UNAIDS, we hosted these meetings very often. And we were discussing. Initially, we discussed how we designed the program to make sure that they are all comparable. We looked at, did we answer all the questions? Then we started meeting to see the progress, how it's going. Are we recruiting enough women? Are we facing hurdles that everybody needs to be aware of? So all these aspects were discussed in these meetings, and in the end, we had really all the scientific community involved in this research that was coming.
So everybody essentially was, I suppose, representing themselves and their research instead of their organization. Is that correct?
Yeah, but effectively, they were also informally presenting their organization because they belong to these organizations.
And were you facing any challenges with that? For example, was there competition between the researchers, or they're sharing their information freely?
Oh, I mean, yeah, it's known. The competition between researchers is known. So in the beginning, of course, there was reluctance in sharing information. Progressively, people felt, yeah, let's make it work because it's for the good cause. We were very careful, to respect the confidentiality of that. People sometimes didn't want to share everything, but they shared the essential. So all that became acceptable, but progressively it created bonds between people, and that's a human interaction, but by definition, which actually ended up to be very effective later on.
Okay. And so was there actually a pivotal moment in terms of cementing that proper collaboration? Because those bumps you spoke about there, how did you make sure they were smoothened out and actually everybody was working, the group was working together for the same purpose?
Yes, there was a pivotal one. We got criticized as the research community for using placebo. People said if women, if the trial ACTG 076, the trial in the US, you should apply it there. We said, but we can't apply it there because women don't come early enough. And so it was more like the idealistic versus pragmatic approach. Because we couldn't apply it, then we needed to test if it's better than nothing. Maybe it's not better than this one, but if we can't apply this one, what's the point? We don't want to keep doing research for 10 years before we find a solution for these women. So this criticism became publicly known. Newspaper wrote about it. We had interviews after interviews. But interestingly, the scientific community came all together because everybody was in agreement. We designed these trials together. So everybody came together and everybody defended and everybody spoke in one voice. So the fact that we were all criticized by these organizations, Public Citizen, which was like a public organization, we came together and it cemented these ties, these links that happened between the community, and it helped a lot speed up the research and really publish the results together. Then people put their data together and made meta-analysis. So it was really favorable to the research because it created these bonds, and then the whole community came with the clear answers and with very good answers that could be implemented later on.
So am I right? Without the placebo, the research could just linger with no conclusive answer or outcome. Is that right?
Yeah, I mean, if you're not aware from the beginning, people say, "Oh, there is a research, but there are aspects that we didn't explore, so now we need to do another clinical trial to do it, and then another clinical trial, and it never ends." The fact that we designed it together, the fact that we made sure we answered all the questions, was very important to produce the results. But putting all the research together to come with much bigger findings was triggered by the fact that these bonds between the researchers were cemented, and in fact it did improve, I would say, the outcome of the research.
And that brings me to, so what was the actual result? You know, you had all worked together for so long. What was the final result?
It worked. Even one pill at delivery could work, and one pill, and then also treatment for the child could prevent it. Not as much as what happened in the US, but prevented it significantly. And this is where it becomes very interesting, in the sense that, so in fact, the outcome of the research is that we had a number of interventions that worked. We knew more or less all of them worked well, but there are ones who work more than other. All depends on when the woman comes, when we identify the woman. But even if the women come only at delivery, then we are still successful. And I think that was the interesting aspect about all this research, is now we had multiple ways to actually prevent the transmission from the mother to child, depending on when we come in touch with the woman.
So it seems now that you were at another crossroads, right? Because you now had the research. You knew it was possible to prevent mother to child transmission of HIV or AIDS. And there were new antivirals available in the market that were turning AIDS, I suppose, from a deadly disease to a chronic disease. Yet you were still in the same scenario because you couldn't treat patients still. How did that impact you and your career choices later as you moved forward?
Yeah, that's and it's the reflection started, I think, with prevention of mother-to-child transmission, and the trial came in parallel. You know, when we did these trials, also the trials showing that with protease inhibitors, that a combination of antiretrovirals could turn the disease from a deadly disease to a chronic disease. So significant impact. And here, yes, I mean, all my colleagues who were researchers, they went back to research. They looked at doing other research because that's what they have done. For me, I'm a clinician, and then I became a researcher because I needed to find a solution. And now we found the solution, but it doesn't mean that the solution is going to be accessible. So given who I am, the normal, I would say, outcome for me is I need to finish the job. That's what I told my friends is, guys, I am going after access because I need to finish the job. So that's yeah. So that's why I got into access. So how do we make these interventions accessible? What does it take? And it was also important for UNAIDS, you know, because Peter Piat said, you know, we can't just ignore the fact that we have treatments and they're not available. I mean, we could talk about COVID and the availability of vaccine and how the WHO is screaming and saying we need to get vaccines to these countries. So that was the same moment. The geopolitics were different. The Soviet Union had collapsed. We had everybody was talking in one voice as one world. There was an enthusiasm for collaboration between the different parties, between the different countries. So we have, so it was really very conducive environment to say, well, what are we going to do now with that world where we were heading to globalization? And Peter Piat said we need to make it available. We need to find a way. We need to discuss with the companies. We need to discuss with government. And who wants to do that? And I volunteered. So I said, I'm going to do that. And that's how we started negotiating with the pharmaceutical companies to find ways to make these products not only available, but also accessible, to make sure that we address the price. We talked, they said, but do the governments have the infrastructure to do it? And the government say, why do you want me to put the infrastructure in place if in the end the treatment is not available? So we said, okay, well, let's sit together and make sure that both work. and that's where we started pilots. Healthcare loves pilots. We need to make sure that it works and to prove the concept. And we did the pilot. So I was responsible for these negotiations and for making these pilots called Drug Access Initiative at the time. And it worked. And we found that in these countries, patients took the treatment the same as in Europe and the US, and there was no difference.
So you had established the first HIV/AIDS drug access program. I think you said it was done in 4 countries initially. Was it Chile, Cote d'Ivoire, Vietnam?
Uganda and Vietnam. Yes. It was about making available. Now we knew the government were not ready yet. They didn't have the budget or to pay for these medicines. But at the same time, we needed to know if giving these medicines. So we asked the companies to reduce the prices. We asked the government to provide some infrastructure and help us in getting there and see if the logistics, because remember, antiretrovirals, they change the course, but they need to be taken for life. And it means chronic treatment. Many of these healthcare systems were not set up for chronic treatment. They didn't have the mechanism to follow patients. You see, and because they didn't have the mechanism to follow patients, then we ended up. Then we needed to set up these systems together, and that's why we started setting them up.
I suppose that leads me to my next question quite nicely, because in emerging markets with decentralized systems, who was distributing the medicine? The medicines, you now had them available. You wanted to make them available within the market. You spoke earlier about infrastructure, but how did you actually make sure that the medicines were being brought to the right people? They were reaching the suitable patients, I should say.
Yes. Well, I mean, first, you need to get the medicines to the market. You need to make sure that you have labs that are providing viral load and the CD4 cell counts to monitor the effect of the treatment. You need to make sure that the physicians are trained, that you have proper guidelines. So there were a number of things that we needed to put in place. Now, that's why we looked at these 4 countries, because they represent different regions with different infrastructure. So sometimes if the public sector, like for example in Uganda and Cote d'Ivoire, is very focused on large volumes of products, where then we need maybe to find alternative supply chain, which we did. Sometimes if they are used to these small high value, I would say small volume products, then we worked through the government system. So we didn't have one size fits all. We just tried to adapt and optimize the system that existed to make sure that the patients get the treatment. And it worked very well. And Uganda was a very successful story in terms of delivery of products, in terms of also follow-up of patients, and even the follow-up of diagnosis.
So were they audited afterwards? How did you ensure that this was actually happening? I know you had told me before that selected groups had to fit a very strict set of criteria even to be able to distribute the medicine in the first place. And was there a way of making sure that that actually was happening, that the plan that you had put in place was actually happening and the medicine was reaching the right people?
Yeah, I mean, we were actually monitoring that, but also it was important to have independent auditors to look at whether this really worked or not, and that's why we agreed with CDC to audit Uganda and Chile. And we agreed with the French ANRS, Agence Nationale de Recherche sur le Sida, to monitor Côte d'Ivoire and Vietnam. And they went, audited, and issued a report. And this was very important because first, these were independent reports done by reputable agencies. And it helped later when the Global Fund and the PEPFAR came they also needed to say, okay, so if we put all this money on antiretroviral, is this really going to work? And it's important to answer that. And they said, yes, we know it's going to work because these are the pilots that were done and these are the results.
Okay, so I mean, at Axios, I've certainly heard you speak about multi-sector collaboration all of the time. You know, it's something that we are continuously talking about in Axios. And how is that, or why was it essential specifically when addressing the HIV issue in emerging markets?
Well, it was essential for HIV/AIDS because, again, we were dealing with chronic disease now. With antiretroviral, it's no longer an acute disease, although it's an infection, but it's the treatment is long-term treatment. The way it would be for diabetes, the way it would be for now rheumatoid diseases, where you need chronic treatment, and for these chronic treatment, you need a different way to address the system. So this is the reason why you need multi-sectoral collaboration. It goes back to the same thing. We need to make sure that the community is embodying. You know, HIV/AIDS had huge stigma. When you are HIV infected, you're rejected by people. You lose your job. The family doesn't want to talk to you. So it's complicated to navigate, and these people need support. And beyond that, the interventions. For example, I can give you an example. In Africa, especially in East Africa, 45% of women deliver at home. Okay? So we said, great. Even if we give the nevirapine, the intervention, to all women in the hospital, the best we can do is 55% of the population, right? So what do we do with the 45%? We need to know where they are. Where are they? They are in their villages, delivered by traditional birth attendants. So we said, okay, we need to give the product to traditional birth attendant. And no, they're not. They're not doctors. They're not pharmacists. They're not nurses. They can't say, but then we need to at least get in touch with them, so that they bring the women to the hospital to get it. So they need to test women. You see, no, they need to be tested at the lab, but we have now finger prick tests, you know. So there were a number of hurdles, but in the end, you have to work with all these people because they are the one who are following these women. Give you an example, but there are many aspects of that. You can't just pretend that you can do it on your own. That's very presumptuous, in my opinion. You have to work with whoever takes care of people inside the hospital and outside the hospital to ensure that you're getting that continuity of treatment.
Yeah, like, I suppose the world has spent the last 2 years, nearly 2 years, battling COVID. Are there any learnings that you could recommend from the HIV and AIDS days that could be implemented in today's strategy for fighting infectious disease?
Oh yeah, plenty, I would say. First, if I learned anything in HIV, is that the scientific community needs to sit together and agree on intervention. You can't leave it to the politicians to decide what to do for public health. And it's not because I don't trust the politician. It's just it's not their job, you know. So, one of the things that happened with COVID is the scientific community didn't speak in one voice. Every country decided to do interventions, lockdowns, whatever, on their own with no consultation. So consultation is very important. If I learn anything, is this one. Otherwise, we're not going to get rid of the disease. We're not going to be able to contain it. So that was my first aspect. The other aspect is related to what I call targeted intervention earlier, meaning you have to focus on the vulnerable and make sure to protect them from the disease. And we knew from the beginning that there were people vulnerable to COVID infection, but we didn't know where they were. Why? Because we don't know what happens to the patients when they leave the hospital. And unless we know, we won't be able to protect them. So we lock down countries altogether. So that's where I think these are lessons that we have forgotten, unfortunately. It seems that the history is repeating itself. So I hope that for the next epidemic we'll be much better prepared.
No, I hope so too. And unfortunately, that has brought me to my last question. So we have run out of time for today. I hope this episode is especially relevant given December 1st is World AIDS Day and the theme for 2021 is ending the HIV epidemic, equitable access, everyone's voice. You've shared multiple insights that could be used for addressing future epidemics or pandemics. And I'd really like to thank you again for your time, Doctor. Once again, I'd like to invite our audience to ask us any questions. If there's a particular topic they'd like to hear Dr. Saba speak about, please feel free to reach out to us on our platforms, and I'll definitely make sure those questions are addressed in future episodes of Health Access Now. So once again, thank you so much for your time. Thank you for our audience for joining us again.
Thank you.
We look forward to seeing you on the 4th episode of Health Access Now. So unfortunately, that's all we have time for today. I really enjoyed this episode and I hope our audience have too. I'd like to thank you, Dr. Saba, once again for sharing your time and your insights with me today. I would like to invite the audience to like and subscribe to our channels, especially if you're enjoying the content. And we look forward to bringing future episodes of Health Access Now. Until then, we'll see you again in December. Thank you.